I'll pass the call to Mr. David Limbrick, MLC.
Thank you, Chair. My first question I'd like to ask Professor Sutton, please. So I questioned the Premier earlier about the end game, and I don't think we quite got to where I wanted to get. So I'm going to follow up that line of questioning with you, Professor Sutton. So the Premier indicated that the suppression strategy that we're using is to get the case numbers down so that they're manageable. That's fine, I understand that. But that still doesn't lead us to an end game. I mean, we either suppress forever until however long it takes, probably decades before everyone gets some sort of herd immunity or a vaccine, or is there some other option here that I'm not seeing? Because this seems to be fairly confusing, because if the suppression is the current strategy and there is no vaccine, then how long does that suppression strategy go for?
It is a wicked problem, Mr. Limbrick. Certainly the suppression strategy is to drive cases down as far as is humanly possible. We can't speak to the feasibility of being able to drive cases down to the point where they disappear. But I think the national strategy, and it's been updated through National Cabinet on the advice of AHPPC, is called aggressive suppression. That talks about there being no community transmission. Other people might call that elimination. The reason it's not called elimination is because it's a recognition that the virus is always there globally. The virus will always be there in international travellers, in maritime crew who might arrive on our shores. And so it is a recognition that we can't get rid of the virus entirely from Australia's shores, but that we can and should aim for no community transmission if it's feasible. I think the alternative is indeed for long-term suppression with the kind of constraints that can manage that. It's highly problematic, it's enormously complex, and it has all of the weaknesses that are kind of playing out in the Middle East, in Asia, in Europe and North America, where second waves come and there's an uptick in cases and a reapplication of restrictions. There may be a path that has very, very low case numbers with a kind of baseline level of restrictions, universal mask wearing, changed human behaviours very broadly applied across the population that can keep those numbers low. But I think it always comes with the danger that it can re-emerge and take off again.
But this sort of strategy that you're talking about, Professor Sutton, how long would that need to go for? I mean, the current lockdown that we're seeing now and the current restrictions are clearly not sustainable over the long term, right? And presumably some less stringent lockdowns might be a little bit more sustainable, but ultimately we have to get back to some sort of normal. And if there is no vaccine available or a cure or something, presumably we'd be following these suppression strategies for decades, wouldn't we?
I think there's significant optimism about the development of a vaccine. There are over 100 that are in various stages of development. Over a dozen of them have gone into phase 2 trials where they're actually exploring the safety and efficacy in human populations, and a number of those are not far away from phase 3 trials where they're actually demonstrated hopefully to be able to provide some protection at a population level. I don't think that vaccine will be available necessarily in the next 6 months, but I do think that there's a very, very good chance that it will be available within the next 12 to 18 months. And so I don't expect that we're looking at years or decades of suppression, but it is a matter for national consideration, and AHPPC are certainly have also put their mind to how do we manage this if there isn't a vaccine? And I think the idea of aggressive suppression is one of those where you can manage without too many population level constraints, very low case numbers, or to actually end community transmission and then manage the risk of re-importation into Australia. But it's not It's not easy to determine the long-term response when it's not yet clear if a vaccine may be available. But I might throw to Professor Cheng, who's an ID physician and might be able to say more on vaccines.
Thank you.
Thanks. I'm chair of the Australian Technical Advisory Group on Vaccines and the Advisory Committee for Vaccines for the Therapeutic Goods Administration. So there are actually over 200 vaccine candidates, and it would be hard to think that at least one of them wouldn't be effective. There are vaccines that are entering phase 3 trials, as Professor Sutton has outlined, and some of these are looking fairly promising in their phase 2 studies. They generate antibodies. Those antibodies can be shown to neutralise the virus. Phase 3 studies are necessarily fairly large and large undertakings, and it is going to take at least some months to work out if these vaccines do indeed work and are safe enough to give to a population. So I would agree that they're probably not going to be ready for deployment in the next 6 months, but I would also be fairly confident that in 12 months or perhaps 18 months that there'll be something available, and that really is a very hopeful step, and there's really quite a lot of resources that are going into this. I'd also say that the pace of vaccine development is really extraordinary. So there are companies that are producing vaccines already, assuming that they might be effective. If they don't turn out not to be effective, they're going to have to throw out a lot of vaccine. But a lot of these steps are being accelerated or done in parallel, so that that we can be ready if one of them is shown to work.
And thank you very much for that. So how much hope are we putting in a vaccine becoming available? Like if it turns out, you sound very confident that we will get a vaccine at least sometime in the future. But if it turns out that a vaccine doesn't happen, I remember back with other diseases like HIV, for example, everyone thought that there was going to be a vaccine, and it turned out that we couldn't get one. If it turns out that we can't get a safe and effective vaccine, are we pursuing the wrong strategy?
I think we have to bear in mind that we're not relying on the development of a vaccine in how we manage this. The reality is that our numbers took off in July under a stage 2 level of restrictions, and therefore going back to that kind of level with our current case numbers would see an exponential increase, and some of the modelled predictions would come to bear, and that means an overwhelmed health system. We are managing with our current daily numbers, but as we've seen, we're looking at 20 deaths per day at those relatively modest numbers when you consider what modelling demonstrates the epidemic could increase to. And so I think we have to look at controlling those numbers and then maintaining them through the least restrictive mechanisms possible. But in the absence of a vaccine, that does require the kind of broad structural and behavioural changes that suppresses transmission enough not to have thousands upon thousands of cases a day and hundreds of deaths. The UK has had over 45,000 deaths and are looking at a potential second wave now. Spain's going through a second wave. Israel's going through a very large second wave. And so the alternative is to see very, very significant morbidity and mortality and potentially overwhelmed health systems. And so we do have to balance with the least restrictive mechanisms the control of the epidemic. But what we were looking at in early July was a very, very rapid and significant increase in numbers that wouldn't have been addressed unless we had gone to these additional restrictions.
Thank you, Professor Sutton. So another question which I raised with the Premier, and I'd be interested in your viewpoint on this, is the harms from the restrictions themselves. Now, we know that the disease causes harm, but also the restrictions itself can cause harm. In economic modelling, they'll term this in quality adjusted life years. I'm sure you're familiar with that. Has there been any modelling at all on the possible damage to quality adjusted life years of the population due to the government interventions to manage this disease? So things like, harm to mental and physical health, potential suicides, poverty, all of these sort of issues that will cause harm. What sort of modelling has been done? Because the question that lots of people are asking is the current actions causing more harm than other possible less stringent actions that the government could be taking?
Very, very reasonable question. And it's been in our minds as AHPPC and myself as Chief Health Officer, but also broadly with Cabinet right through this period. I'm not involved in the specific review of the data across very broad areas that do relate to psychological wellbeing, other harms from reduced access to medical care. But Professor Wallace, CEO of Safer Care Victoria, might be able to speak to some of those broader components, but it's absolutely recognised that there's a balancing of harms here. What's been demonstrated again in Europe is that even with the 30, 40,000 deaths that have occurred in some countries, that's only with between 5 and 10% of the population having become immune. So we would be looking at 500,000 or more cases before some of those countries get to herd immunity. And so the deaths that we might have seen so far in Australia or in other countries are really only a very small proportion of what would be required if we were to let this run and get to a point of herd immunity. So it is a very significant morbidity and mortality. We're starting to see some of the very significant potential long-term effects that involve the respiratory system and neurological and other systems from coronavirus. So it's not just deaths. There does seem to be some chronic incapacity that people are left with as well. But Professor Wallace might speak to some of the broader components.
Thank you, Professor Sutton.
So Limbrick, so thank you. So Euan Wallace, I'm the CEO of Safer Care Victoria, and as you know, we're the state's Quality and Safety Improvement Agency for Health. And from the outset, one of the things that the department asked us to do was to track what we have phrased as unintended consequences. So what are the potential collateral outcomes of restrictions or changes to health provision in response to the pandemic? And right at the very beginning, Safer Care set up a clinical leadership expert group, and they have 11 expert working groups feeding into those, all tracking areas of their own disciplines: stroke, cardiology, maternal newborn health, etc., etc. And there have been changes, and as you might be aware, in presentations to our emergency departments, particularly people with acute stroke, people with acute ischemic heart disease, so heart attacks. And we've provided that advice to the health department, and previously the minister has actually made announcements to the public about, please do not put off urgent healthcare because of the pandemic. So while we were in stage 3 restrictions and now stage 4, if you have urgent health issues, please present either to your family physician, your GP, or to your local hospital ED department or wherever. Similarly, the cancer expert working group are looking at presentations with acute presentations with new diagnoses of cancer. So we're tracking these things very carefully, and that information is fed through to the department, to the minister department proper, and the minister. As I said, the minister has made public announcements to encourage people to come forward.
But they're not coming forward, are they? The rates are very low still.
Yes, so certainly in the first wave, in the first restrictions, there were significant decreases in presentations for heart attack, for stroke, and they've come back. We are too early in the current restrictions to know whether that's going to recur. Our cancer groups have also made have also been tracking acute cancer presentations, and again, they fell initially, hence why the Minister made those announcements previously, and encouraging people not to ignore changes in their own health and come forward appropriately.
Yes, thank you very much. I'm getting close to running out of time. One thing I'd like to ask Professor Sutton, and I think I asked you this last time, was around the issue of immunity, and it wasn't certain at our last hearing whether people had long-lasting immunity when they recovered from the disease. Is there any further updates on that? And my question there is, if someone is immune because they've recovered from the disease and that immunity is lasting, what is the rationale for maintaining the restrictions on their freedoms if they're not going to be a carrier anymore, they're not going to catch the disease? Why can't they participate back in society again?
I might also throw to Professor Cheng on this, but my understanding is that there is good evidence, or there is increasing evidence, that the immunity that individuals get having been infected is potentially substantial. How long-lasting it will be and how protective that immunity will be will only really be borne out as we proceed down the track of this pandemic to see if it lasts beyond 6 months or beyond 12 months. But certainly from the serological tests and other tests of immunity, people do respond with antibodies. They have other effects in their serum that should be an indication of some protection from reinfection, and therefore for those individuals there is some confidence that at least for a period of months, if not several months to years, they will have relative, if not absolute, protection. But Professor Cheng?
Should they get their freedoms back is the question.
Well, I think to the degree that we don't apply requirements for quarantine, or that we'll have individual exemptions for those people who might have been previously infected, then yes, those freedoms are available to them. But we do have some uncertainty about what it would mean to broadly not apply restrictions to individuals. We don't have advice either from WHO or other international bodies about the idea of an immunity passport being a valid approach.
Yes, I'd note that I would have been horrified at the idea of immunity passports a while ago, but now we have work permits. It doesn't seem so bad as a way of getting some sort of freedom back. Yeah, I think I'm just about out of time. So
about.
Yes. Thank you very much.
Thank you, Mr. Limbrick.
Thanks, Mr. Limbrick.